So today's topic of discussion is STIs, are also called as sexually transmitted infections. Now, before going into sexually transmitted infection, there are many terminologies. A very common terminology is called as RTI, or reproductive tract infections. So what are reproductive tract infections? Basically, reproductive tract infections would include any kind of infective process that is going on in the reproductive system. So in females, it would encompass from external genitalia up to the ovaries, including the fallopian tubes, uterus, cervix, and vagina. And in case of males, it would include penile urethra, testis, scrotum. So any infection in these organs or organ system, we can call it as reproductive tract infections. Now, most of the diseases which affect the reproductive tract are transmitted through sexual route. Again, there is another terminology that is called as STDs. STDs stand for sexually transmitted disease. Now keep in mind, over here we are talking about the mode of transmission. The disease may or may not affect the reproductive system or may even affect other systems also. Those are also included in STDs. For example, hepatitis B infection or HIV, they are transmitted also through sexual route and will ultimately involve other systems, like in hepatitis B, it will affect the hepatobiliary system. There is no direct affection on the reproductive organs. Now you are clear? So reproductive tract infections or RTI means all the diseases which affect the reproductive organs. Sexually transmitted diseases are all diseases which are transmitted by sexually. It will also include diseases which may also spread in other ways also. Now, obviously, there are some sociological problem, especially with the stigma associated with infections of the genitals. Now, the name that is proposed today are called as sexually transmitted infections or STI. Now, when we say sexually transmitted infections, it means infections caused by microbes may or may not manifest symptoms, may or may not result in disease. We are only concerned with the transmission. Understood? Now, why it is important? Because earlier the term that was used, or the STD, sometimes even called as venereal diseases, it carried a lot of social stigma. This social stigma prevented people from getting medical benefit when in the early stages of the disease. Furthermore, this terminology has been approved by the WHO, and this has been done with a thinking process for better management of people affected with these diseases. And this mode of management is called as the syndromic approach of treatment. That is the, in essence, the discussion today. Now look at this graph. Now on this graph you can see there are reproductive tract infections, which may or may not be sexually transmitted infections also. For example, look at the example that is given over here. Postpartum infections. Postpartum means infections of the female genital tract after the childbirth. Now these infections are not transmitted sexually. However, they will affect reproductive tract organs. Hence, they are included in the reproductive tract infections. Now look at the infections which are STDs, hepatitis B, HIV. These are STDs, that means transmitted through sexual. But over here we are dealing with STIs, that is infections which are specifically transmitted by sexual route and will affect the genital and the reproductive organs also. Why these are important? Now, this is the Piot-Franzen model in which it shows if we have 100 women who have been afflicted with reproductive tract infections, out of them, about only 50% will be symptomatic, 50% will be asymptomatic. And among the people who are symptomatic, only about two-thirds will seek treatment. Further, less people will agree with the treatment and undergo proper testing methodology. Even fewer people will complete the treatment, and a very important problem that is seen is the treatment of the sexual partners. Less than 1% of the partners of this woman are actually get treated. Hence, this methodology is used over where in this management system, our target is first we have to treat the disease so that the spread of the disease is halted, reinfections do not occur, and we can prevent complications arising in the patients. Now, what is the most common complications of the reproductive infections? Any idea? Okay, we'll say later on. And this can also be a very good opportunity for educating the people, especially the women, regarding safe sexual practices. Now, let us look at the types of the infections which have been categorized. The first type of infection, I think you have already been taught about, is syphilis, caused by the next type of infection is also known as gonorrhea, caused by chlamydia, which serovars, trichomonas, trichomonas vaginalis, then chancroid caused by Haemophilus dictu. Herpes, commonly caused by herpes simplex, predominantly caused by the type 2, type 1 may also cause. Then genital and cervical warts, most commonly caused by human papilloma virus. Good. Next, HIV already you know, hepatitis B, donovanosis caused by donovanosis caused by Klebsiella granulomatis and lymphogranuloma venerum caused by chlamydia trachomatis. Other commonly affected are what is called as molluscum contagiosum and some ectoparasites like scabies and lice, pubic lice, also very commonly called as crab infection. So these are the infections which we get in the STI clinics. But sadly, the patient will not give you the diagnosis. What the patient will give? Patient will give some signs and symptoms. Based on this, now when we say syndromic approach, that means we are approaching from the symptomatology of the patient. The common generalized symptoms that has been divided are: number one is urethral discharge. The patient complaining of a discharge per urethra, or presence of an ulcer on the genitals, which may or may not include itching, pain in the groin or the testis, or swelling in the regional lymph node or the inguinal lymph node, which is also called as inguinal buboes. Buboes means swelling. Then, in case of females, we can find a variety of pelvic manifestations, which would include vaginal discharge, heavy or abnormal vaginal bleeding, dyspareunia, that means pain during or after sexual intercourse, or we can have consistent lower abdominal pain. These are the common symptoms a woman may present in the STI clinic. Few manifestations are common, like blisters or raised nodules, warts. These are common in both males and females. Again, you should also be aware of some generalized symptoms like flu-like illness. This can be seen in no idea. HIV infection of first manifestation key hai, a flu-like illness. The patient may also present like this because HIV can also transmit through that. Even the patient may also present with jaundice. Hepatitis infection may occur. So these are the systemic manifestations a patient may also present with. So you should be aware of all these presentations. Now coming back to this syndromic management, in India we have a national program, that is the national guidelines for the management of STI or RTIs. And according to this program, we have divided the various symptoms specifically. The first symptom is urethral discharge, second is vaginal discharge, third is genital ulcers, inguinal buboes, lower abdominal pain, acute pain in the scrotum or scrotal swelling in males, and genital skin conditions. These are the 7 manifestations a person, whether a male or female, may present with. Now, regarding the STIs, how these STIs can spread either through endogenous or exogenous. I think most of the diseases have been already taught to you, so I'm not delving into all this right now. Coming back to the manifestation, these you already know. In gonorrhea there will be drips, in chlamydia there will be various manifestations. Let us move beyond all this. Okay. Now coming to the complications, what are the complications that might occur if you fail to treat at a proper time? In females, the important complications would be, especially in case of pelvic inflammatory disease, there may be structural or organic damage to the reproductive organs, and which may render the woman incapable of conceiving. So even if the patient gets better after treatment in the infection, the sequelae may lead to or make her infertile. So this is a very common problem. Now, if the patient does comes to you, what you need to do? First, you need to ask about the symptoms. What is the presenting symptoms? I think we are already acquainted with history taking. So after taking the history, you have to inquire about these important symptoms. That is whether is there any discharge to urethra or not, whether there is a vaginal discharge or not, whether there is lower abdominal pain or not. You have to inquire about them. The patient may or may not tell you. Why you need to inquire? For example, in pelvic inflammatory disease, generally it is associated with the lower abdominal pain. Sometimes the pain may radiate into the back, and ultimately the woman may only complain of a low back pain, not even lower abdominal pain. So you need to inquire about all these things. Furthermore, whenever you are inquiring about discharge to the urethra, you need to inquire about whether there is a dysuria or not, whether there is any pain in the groin or scrotum in case of males. All this you have to inquire. Then, very importantly, you have to take what is called as the sexual history. What is the sexual behavior of the patient? What is also the sexual behavior of the partner? You have to inquire about them. Next, you have to inquire about any past history of sexual diseases or not, whether that's a recurrent phenomenon or not. Then you have to also inquire about other. বলো, তোমাকে জিজ্ঞেস করছি, মুখ লোকাল কি বলো, ভালো যোগ বললে, না বলো বলো, আমরা শুনবো, কি দরকার ছিল? Because you see, most of these infections will occur in some selected or specific groups of population, and those are the vulnerable population in all sense, not only economically but also malpractices like injection drug abuse and other alcoholism. So these are also associated. Hence, you need to also inquire about all these things. So now that the patient has come to you, you have taken the history, you have assessed the symptomatology. What would be the next step is to examine the patient. So what do we need to examine? We need to first we have to take a general examination, there is a general survey. পড়া হয়েছে তো general survey তারপর systemic examination. After the general survey, we need to do the systemic examination of the affected region, that is the reproductive system. So what are the system? First is inspection of the external genitalia. Then in case of females, we have to do an abdominal examination and a speculum or a bimanual examination. I think in gynecology you have already no. So GI the abdomen examination পড়ানো হয়েছে? Yes or no? So that's the normal abdominal examination that you have to do. Furthermore, because it affects the reproductive organs, we can assess them by a speculum examination. That is applying a speculum in the vagina and examination of the vaginal introitus and the cervix. For example, if the affected cervix is affected, we can find redness, swelling in the cervix, etc. Furthermore, we have to assess whether these are also inflamed or not. That is called as the bimanual examination. That is, after doing the vaginal examination with one hand, we have to also examine with the other hand the lower abdomen. That is examination of the lower abdomen improper. So this is the total examination of the and in case of males, after the examination of the genital organs, you need to assess if the patient is complaining of scrotal pain or pain in the testis, we have to undertake the examination of the testis, local inguinal region, whether there is swelling of the inguinal lymph nodes or not. Patient may or may not complain, okay, but there might be tender lymphadenopathy in the inguinal region. So you have to also undertake those examination. Even after doing that, please remember this line very importantly: a normal physical finding does not mean that the patient does not have an STI. The patient may come with a symptom. Okay, a male patient may come that I have discharge from the urethra which is almost pus-like, that is pus coming out from the urethra. He may or may not have any other symptomatology or any examination finding, yet you have to treat that patient. Okay, so a negative examination does not exclude STI. Now these 6 C's are very important in case of syndromic approach. They are pretty much self-explanatory. So in your exams, if you are asked about syndromic approach, you have to explain these also. So what are the important part is, first is counseling and education of the patient. About what? About the various sexual diseases, how they are transmitted, we have to counsel them. Then use of contraception, that is the barrier methods, contact tracing, especially in males who they are exposed with. Then very important is compliance with treatment. Most of the time what happens is the person who is affected because of the social stigma, even if he or she seeks medical attention, will ultimately will not complete the treatment. He or she will take drugs for 1 or 2 days, then will stop the treatment. So what it will result in? It will result in reinfection or repeated infections. So you have to make the person understand why it is very important to comply with the treatment protocol. Again, after completing the treatment, the patient has to be followed up. You have to counsel the patient to come back again, because many a times the patient will not come back if his or her symptoms have disappeared. They will think that I have got well, so I will not seek further medical attention. And finally, the most important part is you have to cure the patient. This is the last but most important part. Now, Another important question when we are learning about the syndromic approach is why we should approach. Because in all other types of infections that have been taught to you, what was our approach? Our approach was, after taking the history and clinical examination, we form a provisional diagnosis, along with we have some different differentials. Then we move for confirmatory testing via various laboratory methods. What is the goal of this testing? To get an exact diagnosis, etiological diagnosis, and then we commence the proper therapeutics, whether it's empirical or definitive, as the case may be. That means we are progressing based on the etiological aspect. Understood? But over here, we are trying to go for the syndrome wise. We are not concerned about what is the exact etiology. Why is that? Because first is, many a times a diagnosis can be achieved based on time and place. Why? A tertiary center may have various investigative methods, whereas a district level hospital or a peripheral health center may not have. So you cannot withhold treatment. Once this patient comes to you, very unlikely you will get the patient to follow back. So whenever they come to you, you have to initiate treatment. Otherwise, these people will go on spreading the disease in the community. Next is, in etiological diagnosis, we use antimicrobial agents very specifically and very directively. That means we do not recommend over treatment. But over here, over treatment has to be done for the obvious reasons. Most importantly, in etiological approach, you need to get the patient come to you repeatedly. Right or wrong? He will come to you, take the history, examine him or her, you recommend some test, he or she will go back to the laboratory, get the test done, again will come to you, then you will prescribe. These patients will be lost to follow up. But in syndromic approach, because you are not going through all the process, the chances of loss to follow up will be very less. So, in essence, this is the most important aspect of syndromic approach. And finally, there is very less reliability of laboratory reports. In a country like India, where there is a huge disparity between resources from one state to the another, from one city to other, effective treatment may not be given to all people if we proceed for the etiological diagnosis. But if we go by the syndromic approach, an effective and methodical treatment can be provided to almost all people of India by this method. বোঝা গেছে? Essence of syndromic approach? Yes or no? কিচ্ছু ঢোকেনি মাথায়? সবাই পাথরের মতো বসে আছে। Now let us look at the specific symptoms one by one. First is urethral discharge in males. Commonly, these are associated with the diseases like gonorrhea, chlamydia, and trichomoniasis, caused by, obviously, positive. Now, if this patient comes, what you need to do is, next step, chalo, you people get involved. একজন করে এসে বলবো, you will read out. লজ্জা পাওয়ার কি বল, পড়ো, তুমি প্রথম থেকে পড়ো। urethral discharge in males.
Management of urethral discharge or burning micturition in males. Syndrome, urethral discharge in males, STI or RTIs, gonorrhea, chlamydia infection, trichomoniasis. Causative organisms, Neisseria gonorrhea, chlamydia trachomatis, trichomonas vaginalis.
So that means when a male patient comes to you with urethral discharge, you will be thinking about these three diseases. What would be the next step? Yes.
History of urethral discharge, pain or burning while passing urine, increased frequency of urination, sexual exposure of either partner, including high-risk practices like orogenital sex.
So these are the important history you have to take. Now, why you need to take history of dysuria? Many a times it may be associated with urethritis. See, urethral discharge is because of the urethritis. Many a times there will be associated cystitis also.
Examination. Look for the urethral meatus for redness and swelling. If urethral discharge is not seen, then gently massage the urethra from the ventral part of the penis towards the meatus and look for thick, creamy, greenish, yellow or mucoid discharge.
That means there will be pus. Sometimes it happens is that when you examine the patient, there will be a collection of pus. And if it is not there, what you need to do, you have to extract the pus. Because ultimately the organism will be present in the pus. Next, when you have examined and you have collected the pus, next step would be to go for laboratory diagnosis if possible. That means if the facilities are available. So what would be the laboratory diagnosis that you can do?
Gram-stain examination of the urethral smear will show gram-negative intracellular diplococci in case of gonorrhea. In non-gonorrheal urethritis, more than 5 neutrophils per oil emulsion field in the urethral smear or more than 10 neutrophils per high power field in the sediment of the first void urine are observed.
Okay, let me explain this. See, urethritis can be gonococcal urethritis or non-gonococcal urethritis. If it is a gonococcal urethritis, we can look for gram-negative diplococci, intracellular gram-negative diplococci in the pus that is collected. Now, if it is a non-gonococcal urethritis, commonly caused by chlamydia. Now, chlamydia cannot be detected by microscopy. You need to go for nucleic acid amplification tests, which are not easily available. But what we can do is we can look for the first void urine. What is first void urine? আমি একটু just divert করছি from this point because you have যখন we have to take the history, we need to differentiate between urethritis and cystitis. Cystitis means inflammation of bladder. So in both the cases, the patient will come with a complaint of dysuria, that is pain during urination, right? If there is urethritis, the patient will what the patient will say? The patient will say, when I start to urinate, there is pain. But when I go on continue urinating, the pain slowly decreases, but it is not painful anymore. But if the patient had cystitis, what he will say? He will say, as long as I am urinating, there is a consistent pain. বোঝা গেছে? Furthermore, if there is urethritis, the organism will be present in the urethra. So if we take the whole urine sample, the probability of getting the organism will be even less. But if we take the first void, that means the initial part of the urine will flush out the organisms and we can get the organism in that sample. That is the reason why in case of non-gonococcal urethritis, the best sample would be the first void urine. Try to recall, for diagnosis of urinary tract infection, we advocate for the midstream urine, where the first part of the urine is discarded. Obviously, because of organisms present in the urethra. But over here, that is what exactly we are looking for. Hence, we recommend of the first void urine. Now, in that, in the microscopy, as I have already said, the best method would be a nucleic acid amplification test, but it may not be available. So, alternatively, we can look for the microscopic result. That is either 5 parcels per oil emulsion or 10 parcels per high power field. That would indicative of non-gonococcal urethritis. Next,
As dual infection is common, the treatment for urethral discharge should adequately cover therapy for both gonorrhea and chlamydial infection. Recommended regime for uncomplicated gonorrhea plus chlamydia. Uncomplicated infections indicate that the disease is limited to the anogenital region anterior urethritis. Tablet cefixime 400 mg orally, single dose plus tablet days of start of therapy. When symptoms persist after adequate treatment for gonorrhea and chlamydia in the index clients and partner, they should be treated for trichomonas vaginalis. If discharge or only dysuria persists after 7 days, then tablets skenidazole 2 gram orally, single dose, to treat for trichomonas vaginalis. If the symptoms still persist, then refer to higher center as early as possible.
Now let me explain this. Because we are not going for etiological diagnosis, we need to treat for both gonococcal and non-gonococcal. Okay. Antimicrobial agents have been taught to you, so I'll just give you the specific answers. I won't complicate. For gonococcal, we give cefixime 400 mg. Okay, it's a beta-lactam drug. It is right cephalosporin, and it is highly effective. And more importantly, it is available in the oral form. For non-gonococcal urethritis, we recommend treatment with azithromycin. Okay, so these are the two drugs that has to be given, and then we have to ask the patient to return after 7 days, because if it is not, it still persists. That means it could possibly because of trichomonas vaginalis, which is actually present in where maybe his partner is affected with trichomonas vaginalis. Okay, so that means repeatedly is getting infected by the partner. Hence, now we have to, after we have treatment, we can give seclidine. It's a drug that is given for anaerobic, like metronidazole. I think you have heard metronidazole, tinidazole. The congener of tinidazole is seclidine. We can give the treatment. Okay. Next part is Madhigata.
Symptom-specific guidelines for partner management. Treat all recent partners. Treat female partners for gonorrhea and chlamydia on same lines after ruling out pregnancy and history of allergies. Advise sexual abstinence during the course of treatment. Provide condoms. Educate about correct and consistent use. Refer to ICTC for testing of HIV and syphilis. Schedule return visit after 7 days.
Thank you. Now, try to understand this. This is an ongoing process. If the person has a partner, it is highly likely both of them are affected. So, if you treat only that person and if you don't treat his partner, what will happen? You will get better and get reinfected, and this cycle will go on. If we need to interrupt this cycle, we need to treat both the patient and his partner. Understood? For that, what we need to do, we have to treat the partner, and also we have to counsel them for attaining sexual abstinence during therapy. Thereafter, we have to counsel them to use barrier method of contraception. More importantly, you have to follow up his partner also after 7 days. Why? I'll come to it later. Okay. Now, regarding management of the partner, if the partner is pregnant, it is slightly more complicated. I will not be delving into that today. But please remember, there is a separate set of guidelines which we need to follow if the patient's partner is pregnant. Because there are some group of drugs which you can give in non-pregnant state, but you cannot give in pregnancy. Okay. So that was all about urethral discharge in males. কিছু ঢোকা যায় মাথা? Okay. Next, just ওখানে দাঁড়িয়ে
Management of scrotal swelling.
একটু জোরে বলো যাতে সবাই শুনতে পারে।
Management of scrotal swelling. Syndromes, scrotal swelling, STI or RTI is positive agents are Neisseria gonorrhea and Chlamydia trachomatis, causing gonorrhea, chlamydia.
So the other manifestation in males that can be seen is pain in the groin associated with scrotal swelling. Same organisms may also cause. Now, in this case scenario, what we'll have to do?
Management of scrotal swelling, history, intracellular
Okay, it's the same. Now, after you have taken the history, from the examination point of view, these are very important. We have to exactly look for whether there is scrotal swelling or not, whether there is testicular tenderness or not. Now, two very common findings that can be seen in case of scrotal swelling is there may be hydrocele or there may be lymphedema. We have to rule those out. Those are not related to sexually transmitted diseases. Furthermore, if there is pain in the testis, you need to confirm whether there is any common causes of pain in testis is testicular torsion and another trauma. How can we rule out? Taking the history. So those has to be excluded. Okay. Next, obviously the same for gonorrhea and chlamydia, same diagnostic methodology. These are the differential diagnosis. And now, as far as the treatment is concerned, because the etiological agents are same, the treatment will be same. Now, what will be the management of the partner? Same. Only remember two things: the difference between an urethral discharge because of a gonorrhea or a chlamydial infection and a painful scrotal presentation is that if not treated properly in time, it may lead to subfertility and even infertility. Furthermore, it may lead to pelvic inflammatory disease even in males. Okay. So these are the two different kind of presentation that may occur. Next,
management of inguinal
bubo means swelling.
syndrome, inguinal stated refer to high central for
Okay. So management of inguinal bubo means swelling in the inguinal region. Specifically, inguinal. We are looking for inguinal lymph adenopathy. So whenever a patient comes with inguinal lymph adenopathy, that is a pathology that is going on in the lymph node, it may be painful or sometimes painless. So we need to ascertain whether it's painful or not. So the patient may complain of tender lymphadenopathy. বলো টেন্ডার লিম্ফ্যাডিনোপ্যাথি মানে কি? তোমাকেই জিজ্ঞেস করছি। টেন্ডার কথাটা মানে কি? জ্ঞান বিতরণ করছিল তো, বলো। পেনফুল আর টেন্ডারের মধ্যে পার্থক্য কি? কেউ বলতে পারবে? When there is pain on palpation but touch, it is called as tender. ঠিক আছে? Painful মানে even without touching, if it is painful, giving pain, we will say it's a painful swelling. But if it is painful only when it is pressed or touched, we will call it as tender lymphadenopathy. So that is an examination finding. Next, what we need to do is we need to look at the condition of the skin overlying the swelling. Furthermore, we have to look for multiple sinuses present or not, because this is very commonly seen with tuberculosis. Tuberculous lymphadenopathy will ultimately will have cold abscess. Cervical is a common presentation. তার মানে ইমিউনালে হবে না এরকম কোথাও লেখা আছে? হতেই তো পারে, তোমাকে ডিফারেন্সিয়েট করতে হবে। Other lower limb infections, any fungal infection in the lower limb may lead to a limb swelling in the lymph node. So you have to rule those out also. After having ruled out, you have to ascertain that this may be because of either a chancroid or an LGV. Please do not try to aspirate from an inguinal lymph node without proper uh, in proper setup. Okay. PHC তে থেকে বসে inguinal view পেলে do not aspirate. Okay. Aspirate only when you have a proper setup. And never even think to try to incise it. The only methodology is you can go for aspiration if you do have proper backup setup. If you don't have backup setup, rather do not aspirate. Okay. Now, for the treatment of this condition, we have to give the drug doxycycline for a period of 21 days. This is for the LGV. And for chancroid, we can go for azithromycin. Similarly, like previously, we need to treat all the persons who have come in the sexual contact with this patient in previous 3 months. এবার যখন আমি বলছি previous 3 months, that means we need to do contact tracing. Similarly, we need to also treat the partners. Next comes জোরে বলো, তুমি কি গান শুনছো নাকি? Carry on. হ্যাঁ, what is an ulcer? এটা তো পরে পড়বে, আগে বলো what is an ulcer. What is an ulcer? Upper layer of, তাহলে আলসার শুধু স্কিনেই হয়? তাহলে বলো, it is the breach or discontinuity of skin or mucous membrane is an ulcer. Simple. বড়গুলো দেখতে পাচ্ছ তো, বলো তাই। কি কি হয়? syphilis, chancroid, and genital herpes. Syphilis is caused by Treponema pallidum, herpes by herpes simplex virus, and chancroid caused by, to bolte daw. Now we have to take the history of the ulcers. The first history that we need to is what is the type of ulcer, whether it's a vesicular ulcer or a recurrent ulcer. যদি হারপিস হয়, there will be repeated infection. পেশেন্ট কি বলবে? প্রায় হয় বা আগেও হয়েছে। What is vesicle? Fluid, elevated swelling, very small and fluid filled. So that is the typical presentation of herpes infection. Or burning sensation in the gend, that is painful. Obviously sexual history you have to leave, and on examination you have to look whether the ulcers are single or multiple. In herpes infection, chances there are multiple ulcers, vesicular ulcer, highly painful, and linguinal lymphadenopathy may or may not be there. Now, based on that, in syphilis we have painless ulcer. Ulcer will be there, but the patient will not complain of the pain. But painful ulcer will be seen in case of herpes and in chancroid. Generally, chancroid present with a single ulcer, and it has a very short incubation period, about 3 to 5 days. So the patient will have a definite history of sexual encounter recently, that is in less than 1 week. So what are the investigation that we need to do is, what are the investigation we need to do? No idea. হ্যাঁ, কক্সক্রিউ কিসের জন্য দেখা যাবে বলো তো? কোন অর্গানিজমে তুমি দেখতে হবে কক্সক্রিউ বলে? আচ্ছা, ট্রিপোনিমা প্যালিডাম এমনি মাইক্রোস্কোপে দেখা যায়? সিফিলিসের জন্য কি কি টেস্ট করা হয়? আরপিআর টেস্ট আর ভিডিআরএল আর আরপিআর। মাইক্রোস্কোপিতে কি করা, মাইক্রোস্কোপি করা হয়? কোন কি করা হয় মাইক্রোস্কোপিতে? এফটিএ এবিএস ডাইরেক্ট মাইক্রোস্কোপি করা হয় কেন? আরে মাইক্রোস্কোপির সঙ্গে কালচারে কি সম্পর্ক? কালচার তো পড়ে, মাইক্রোস্কোপি কেন করা হয় না? সিফিলিসটা একটা মানে ট্রিপোনিমাতে একটা স্পাইরোচিট, তার একটা লেন্থ আছে আর তার উইথ আছে। দ্যাট উইথ ইজ লেস দ্যান 0.2 ন্যানোমিটার। দ্যাট ইজ দ্য রেজলিউশন অফ নর্মাল মাইক্রোস্কোপ। যার সাইজ নর্মাল রেজলিউশনের থেকে ছোট, তুমি দেখতে পাবে তাকে, ঠিক আছে? For diagnosis of syphilis, we have to rely on the serological test. Commonly, VDRL and RPR is very commonly done. Other definitive diagnosis can be done with the help of what type of TRUST or TPHA or TPI, but they are not available commonly. Commonly available are RPR and VDRL, which can be done. Furthermore, now look at the treatment over here. এইখানে আমাদের তাহলে কি কি ট্রিটমেন্ট দিতে হবে বলো? We are looking at these diseases. Now for herpes we need, what is herpes? It's a virus, so we need to give an antiviral agent, right? For syphilis we need to give an anti-treponema agent. কি দেওয়া হয়? Still today the best drug for treatment of syphilis is penicillin, so we need to give penicillin. And regarding LGB and chancroid, we need to give beta lactam drugs. একটা হেমোফিলাস করে, আইএলজিবিটা কে করে? লিম্ফোগ্রানুলোমা ভেনেরিয়াম কে করে? এই তো একটু আগেই তো বলা হলো। আচ্ছা, নাও লুক এট দিস। আমি কি বললাম? যদি ছোট ছোট ভেসিকুলার আলসার থাকে, মাল্টিপল, হাইলি পেনফুল, দ্যাট মিন ইট প্রবাবলি ইন্ডিকেটস হার্পিস ইনফেকশন. If that is the case, we need to give antiviral. The antiviral agent that is given is acyclovir, given 400 milligram for 7 days. If it is indicative of non-herpetic syphilis হতে পারে, অন্য কিছু হতে পারে, then we need to give, তাহলে সিফিলিসের জন্য দিতে হবে, কি দিতে হবে? পেনজাথিন পেনিসিলিন. Dose is about 2.4 million units IM, repeat after 7 days. Along with that, we need to give azithromycin. It will take care of both LGB and SHAM. ঠিক আছে? এর সঙ্গে for all patients complaining of sexual symptoms or the diseases, you have to go for testing of ICDs, মানে HIV, hepatitis B and C এর testing করাতে হবে, because these diseases will not manifest with genital symptoms. Okay. And similar to এইখানে একটা জিনিস, এই একটা পয়েন্ট মনে রাখলে মনে থাকবে, যদি জেনিটাল আলসার ডিজিজ থাকে, you have to look for each and every partner in last 3 months. Why last 3 months? Of why syphilis? আলসার ডিজিজে কি কি বললাম? সিফিলিস হতে পারে, শ্যাঙ্ক্রয়েড হতে পারে, এলজিবি হতে পারে, আর হার্পিস হতে পারে। শ্যাঙ্ক্রয়েডের ইনকিউবেশন পিরিয়ড কত বললাম? রাউন্ড অ্যাবাউট 5 days. হার্পিসের কি হবে? লেস দ্যান 1 week. এলজিবি হচ্ছে মোটামুটি 3 months, and for syphilis it is about 90 days, close to 3 months. Hence, if there is genital ulcer disease, male or female, you have to trace all partners in last 3 months, and obviously you have to treat them. বাদ দাও, pregnant womenদের বাদ দাও. Next, we look at vaginal discharge. Obviously, it will be present only in the females. Now, vaginal discharge can be caused by either what is called as vaginitis. Don't get confused with vaginosis. Bacterial vaginosis is different, vaginitis is different. Then trichomoniasis or trichomonas vaginitis or cervical herpes or say bacterial vaginosis. Nosis means alteration of the local microbial flora. Understood? It is not invading. That means inflammation is not seen. That is called as bacterial vaginosis. In vaginitis, there is inflammation. That means there is a positive outcome. Now, commonly we see vaginitis caused by organisms like Gardnerella vaginitis and Mycoplasma. Sometimes fungus like Candida can cause vaginitis and parasite trichomonas. Sometimes vaginal discharge can be because of a herpetic lesion within the vagina, that is the cervical herpetic lesion. So secretions may come out from the cervix and present in the form of vaginal discharge. So this can only be confirmed with the help of a speculum examination. Earlier I have already told you, in case of females, speculum examination is very important. Over here you can see in this picture, a speculum is inserted pervaginally and the cervix is examined. Now, what we need to do, please remember, in all female patients you have to take the menstrual history. Why? Exactly, you have to rule out pregnancy, and you can do that by taking menstrual history, last date of last menstrual period, and you have to go for an urine pregnancy test, and you have to rule out pregnancy. Next, all the symptoms can be there. What is the discharge in amount? What is the color of the discharge? Okay, then whether it is associated with a burning sensation or not. This is very commonly seen with vaginitis, especially with Candida vaginitis, where burning sensation is usually there because of, especially during urination, because of the inflammation in the perivaginal area. Furthermore, because of the ulcers, there may be swelling in the vulval region, and for example, if there is a herpetic lesion in the cervix, the patient will complain only of scanty discharge, not heavy discharge, and along with that, she may also complain of dyspareunia, that is pain during intercourse or lower abdominal pain. This you have to also accept. So, as far the examination is concerned, see, some of the diseases may have some specific manifestations, like in trichomoniasis, it is greenish color discharge is seen. In case of candidiasis, it is whitish discharge, but sometimes you may not be able to ascertain properly. Even then, you have to go for the treatment. And if there is cervicitis, you have to do a bimanual pelvic examination. Bimanual means after pervaginal examination, you press other hand on the uterus and try to compress. If the patient complains of pain, that means there is inflammation in the ureterogenital region. That would indicate pelvic inflammatory disease, which is a different treatment is different completely. Okay. Now for treatment, what we need to give for vaginitis, we need to go for and these are mainly caused by anaerobic bacteria. And also trichomonas is treated with anaerobic drugs like metronidazole. Effective treatment can be given with seclinidazole or tinidazole. Both act on anaerobic bacteria and trichomonas. Now, for cervical infection, we need to give, recall, gonococcal and non-gonococcal. তাহলে cefixime azithromycin. And if we suspect Candida, Candida is a yeast, it's a fungus, so we need to give an antifungal agent. So commonly fluconazole is given. Clotrimazole may also be given in certain situations where fluconazole cannot be given. Okay, so now you can see that fluconazole can be given in a single dose in the vaginal pessary. Vaginal pessary means that, drug is kept in the vagina itself. So not only it has systemic absorption but also local action. Now next important manifestation is a female coming with a lower abdominal pain. Now this lower abdominal pain may be manifestation in various ways. First is specific pain in the lower abdomen. Second is continuous low back pain. Patient may also complain with dyspareunia, sometimes tenesmus. What is tenesmus? That is a feeling that she needs to defecate but no stool comes out. This happens because of contraction of the uh, rectal muscles. This happens because of the irritation that is going on in the pelvis. Yes. So these all can be the manifestation, either in a single manifestation or multiple manifestations. Now, generally, pelvic inflammatory disease is caused by gonorrhea or chlamydia or mycoplasma gardnerella and commonly anaerobic bacteria. Now, what history that you need to look at? First is lower abdominal pain, fever, cervical, vaginal discharge, menstrual irregularity, dysmenorrhea, dyspareunia, dysuria, tenesmus, low back pain, and most importantly, you have to get the history of contraception. Some of the methods of contraception use intrauterine contraceptive devices. Presence of any foreign body may accelerate the process of inflammatory disease. So this is very important that you have to take the history. Again, like general examination and abdominal pelvic examination you have to do, and you have to rule out pregnancy. For pelvic inflammatory disease, you need to send some of the investigation. First is a wet smear examination of the vaginal discharge to differentiate between whether it's a vaginosis or a cervical discharge. Next, you need to look for direct microscopy whether it's a gonorrheal infection or not. Also, you need to look for complete blood count and urine microscopy to differentiate it from urinary tract infection. Having done all those, there are other very common causes also, like an ectopic pregnancy or an ovarian tumor. These are all the non-infective causes. You have to rule these out also. So these can be very easily done with the help of an ultrasonography examination that you can recommend. Prescription লিখে দিলে একটা ultrasound, but you have to prescribe some drugs. What are the drugs you have to give? First is for gonorrhea, you have to give cefixime. For pelvic inflammatory disease, you need to give doxycycline 100 mg for 2 weeks, and along with that, you have to give symptomatic management with ibuprofen, and Rantac is given for prevention of acidity. Remove any kind of intrauterine contraceptive device if present. Most importantly, ask the patient to follow up. If the condition deteriorates, you need to admit the patient and go for intensive treatment. It could include even surgical options, but you cannot make sure you don't lose the patient in the follow-up. Along with that, sometimes the patient may also present with anal or oral symptoms. If there is unnatural sexual practices may be seen, commonly syphilis, gonorrhea, chlamydia, trachomatis will cause the infections. So you have to delineate other symptoms, and you have to ascertain among all those syndromes and treat them like that. Other than this, these are the common syndromes. Other infections that you may get would include warts caused by human papilloma viruses. These are some of the types of perianal, vulval or penile warts. Okay. Another common finding is molluscum contagiosum caused by molluscum contagiosum virus. You can find this kind of small umbilicated swelling. Umbilicated means there is a depression, central depression. This umbilicated swelling may be present, and they also have a phenomenon that is auto inoculation. That is, it will be itchy. So if the patient itches and then again uh, with the same finger each another part of the body, you can find a lesion over there also. Another is this is called as pediculosis pubis or lice. This can spread because of the pubic hair and genital scabies. This can also spread sexually. Now, till now, I have told you about the various syndromes, how to approach and how to treat. There are many types of drugs. As far as the national program is concerned, we have specific packets that have been given also color coding and number coding, so that whenever you put any patient in any of these syndromes, you can give them one packet for the third. Okay, like for example, if the patient comes with urethral discharge, we need to give this packet. This is the kit 1 and it is color coded in gray. What does it contain? It contains azithromycin and cefixime. So right there you can initiate the treatment. Similarly, also for cervical discharge, same gray packet because organisms are same, and also for painful scrotal swelling. So the first three symptoms recommended is kit 1, color coded gray, contains cefixime and azithromycin. Next would be vaginal discharge. Over here, what are the drugs present? First is a anaerobic, that is seclinidazole and fluconazole. Fluconazole is an antifungal drug. Targeted is trichomonas and candida. Color coding is green and code is 2. Next comes genital ulcer. I have already told you there are two types of genital ulcer, either herpetic or non-herpetic. For non-herpetic genital ulcer caused by syphilis, LGV. For that we have two. First is the white pack or kit 3. It contains benzathine penicillin, 1 vial, which has to be given right in the center itself, and azithromycin single dose, so that the drugs can be given right there. If the patient has an established allergy to penicillin, then alternatively we can go for the kit 4, which is color coded in blue. Over here we have azithromycin, but in place of penicillin we have doxycycline. Understood? So this is for the non-herpetic ulcer. In case of herpetic ulcer, it is the kit 5, color code red. It contains acyclovir. Now acyclovir has to be given 400 milligram tablets 3 times daily for 7 days. Next is lower abdominal pain. Kit is kit number 6, color coded yellow. It will contain cefixime, metronidazole and doxycycline for 14 days. Doxycycline and metronidazole for 14 days. And finally, for inguinal swelling or inguinal bubo, we have kit number 7, color coded black. It will have azithromycin and doxycycline, which has to be given for 21 days. In all the syndromes, you have to follow up the patient by 7th day. But for lower abdominal pain, you have to follow up the patient on 3rd, 7th and 14 days. Why 3rd? You need to ascertain whether the patient is getting better or not. If the patient is not getting better, refer the patient to a higher center. Okay. Same you have to do at 7 and 14 days in case of lower abdominal pain, because you are looking at pelvic inflammatory disease. And in case of inguinal bubo, you have to follow the patient up after 21 days, whether the patient has completed the treatment or not. Because it's 21 days, a long period of time, many a time the patient will not complete the treatment. So you need to follow up. So that was all about syndromic approach.